Thanks, Zach, and thanks everybody for joining us. But anytime you can't hear or if you can't see, feel free to pop a comment in the chat box, like was said before, or just pipe up. You won't hurt my feelings. But I want to start off by thanking, really not everybody I don't think everybody's here, but as Leo said, this is a larger collaborative, and we got to meet in Boston and Northeastern a few months ago, or almost a year ago, probably. I want to thank Leo, Zach, Maya, and others that really were the impetus for this getting going. And Zach for all of his hard work on the website. I think there's been a great response thus far, and it's really exciting to be able to be the first one to do these webinars to talk about our linguistics research, which has a heavy focus that's on the website for changing the narrative, and let all of you know a little bit more about the empirical backing for this. I'll preface this with this. There's a lot of slides in here, so I am going to skip some of them or very briefly touch on them, as opposed to if we were doing this at a conference or a bigger session. Zach didn't. He said I wouldn't talk or wouldn't allow me to or force me to speak for multiple hours, but really I could probably speak for about 10 on these topics. So this is a very condensed version. So when we get to the end of it, if we don't get to your questions or if you want to talk more, if you want the underlying research, the PDFs, feel free to connect with me through Zach or on Twitter. You'll see my handle down there. Send me a message and we'll make sure you get everything that we're going to talk about today. So we'll get right kind of to it. So a little bit about me for those that don't know. So I am a macro social worker, which is a systems level social worker. I don't do individual or clinical work, but more importantly, I'm a recovery scientist, which is a term probably many of you have never heard. So as opposed to addiction science, which is really around characterizing and looking at the disease of addiction or substance use disorders more broadly, our team and our work and the other recovery scientists across the country and the world are really focused on the process and phenomena of recovery from substance use disorders, mental health disorders, and other behavioral health disorders. Looking at characterizing both how people recover, changes in their lifestyle, their sense of purpose, interpersonal outcomes, changes in communities, etc. Not just looking at addiction and perhaps recovery as just a primary outcome of did somebody recover, yes or no. We're much more concerned with everything that has to do with recovery as much more than an endpoint and like a process. So I'm also a PhD student at the University of the Sciences, at the Substance Use Disorders Institute. I'm an RA at the Treatment Research Center at Penn's Perelman School of Medicine, and then a research assistant at NIDA in the intramural research program with Dr. Curtis. I'm the managing editor at the field's first journal dedicated to recovery. It's the Journal of Recovery Science. And then my wife and I have a recovery community organization, which is a nonprofit that provides community-based recovery supports for free here in Philadelphia. And we actually have a trauma-informed and recovery-centric yoga studio that's attached to that my wife runs that we're really proud of. I'm also a person in recovery, but most important, I'm a new dad, which you can see my daughter there on the screen, which I love putting her in my slides now. So her name's Penelope, and she's one of the greatest gifts that my recovery and all the work that I've done and gives it meaning. So let's get right into it. So a brief primer on recovery, if you're not familiar. Essentially there is a tremendous amount of different definitions of recovery. And the takeaway here is that over the last 20 years and even before that, the field kind of writ large can reach no kind of consensus definition of recovery. Sometimes there's abstinence included in that. So does somebody use substances or not? There's predilection on returning, being a self kind of fulfilling and contributing member of society or returning citizen, all sorts of different things, some with various merits and weaknesses. But for us as recovery scientists, and it sets the stage for the work that we're going to talk about today and why it's important, we're looking at recovery as an individualized, intentional, dynamic, and relational process involving sustained efforts to improve wellness. So no predilection on abstinence, though it certainly is a characteristic and a desired outcome for some people's recovery. We're much more concerned to this process as very unique to the individual, that it's some type of intentional action that they're taking, that it's dynamic, meaning that it can change over time, that it's relational, so both relation to oneself, but also the relationship externally to communities, to family members, to peer groups, etc., relationships to systems as well. And then it's really just around improving wellness. So it has nothing to do with substance use unless somebody's individualized recovery has to do with that. It includes harm reduction, both little h and big H harm reduction, And really, whatever is between a person, their community, or their doctor, or other medical professionals, therapists, etc. For us, that's what recovery is, and it guides everything we do, including our stigma and bias research that we're going to talk about today. So we published this if you're interested in learning more about our kind of exploration academically around this definition in the Journal of Addiction Research and Theory. Came out last year. It's a great paper. The Recovery Science Research Collaborative is about 40 different scientists that put that paper out. So moving into what recovery looks like in the U.S. and why this is important is it sets the stage for when we're using language, who are we talking about? What is the prevalence of these communities? And why is it even important? If it was 5 people, does that have as much import if it's 50 million? So our best guess, at least here in the U.S., comes most recently from the National Recovery Study. It estimates about 9% of the U.S. population, and this is 18 and over, non-institutionalized, has resolved some type of alcohol and other drug problem, and we'll leave it at that. So not necessarily, it doesn't differentiate between mild, severe, moderate. It's just somebody has identified they used to have a problem with alcohol and other drugs, and they have resolved that through some means. About half of those, or about 4.5%, actually identify as people in recovery. So if you've been in this field, you may continuously hear the 23 million in recovery number. And while not incorrect, it's a little bit of a misnomer. So there's about 22.1 million that have resolved an AOD problem, and only about 11 million that would hold on to the moniker or identity as a person in recovery. Of those, only slightly over half actually resolve via an assisted pathway. So this would be some type of use of formal support mechanisms. So whether that's treatment, medications, collegiate recovery programs, recovery high schools, et cetera, et cetera. So what this is telling us, again, this is all tied to characterizing the community and how we discuss them, how we relate to them, how we characterize them. Most people spontaneously recover. They recover naturally, as we would call it in the field. They don't require any type of formal supports to do so. And this lines up with some other previous studies around a recovery prevalence or AOD resolution of about 9 to 10%. If we included mental health in here as a larger behavioral health spectrum, that number can balloon up to 25 to 30%. So we're talking about anywhere between 30 and 60 million of directly impacted individuals when we talk about how we discuss these things. What is our language that we use? What is discriminatory policy? Directly impacted individuals is somewhere in that range. And importantly, that doesn't include direct loved ones, family members. And if we did include them and people that could be impacted by stigma and bias, that number could skyrocket to well over 120, 130 million. That all to be said, and again, why this is important is the language we're talking about, stigma, bias, and discrimination, as it concerns with people who use drugs, people that may have a substance use disorder, as well as people in recovery, is quite a prevalent process and phenomenon and identity across the country. And it would be that way even if we weren't in what the media has kind of characterized as an overdose, an opioid epidemic. Really, it's an addiction epidemic, of a polysubstance use epidemic. So this doesn't just mean just because of overdose and opioids are the hot topic, and probably well so. This is a much more prevalent issue and why language may matter. So briefly, in these slides, we're going to kind of skip through, but as we look at the kind of basis of what started the linguistics and stigma discrimination research, it really came out of grassroots organizations of people in recovery that were saying, you know what, we don't like being called and characterized as addicts and alcoholics and substance abusers. So some of these national NGOs had created some recovery messaging. Here's one from Faces and Voices. It was one of the originals that was really around messaging to the media. So, and how to tell recovery stories, which is a kind of a feature and hallmark of people in recovery, to stop using that language even about themselves. So to using positive person first language. And if you've heard people advocate or talk to you, if you're in the media, you might have heard somebody say, hey, my name's John. I'm a person in long-term recovery. And what that means for me is X, Y, and Z. That's where that originated from. Yeah, it grew out of that, from that favor training in the mid 2010s to this idea of recovery messaging, so that the language used was much more important than just when we were advocating for policy change or talking to the media. It really mattered in all aspects of where we were talking about substance use and recovery writ large, that we should always use these kind of positive person first language mechanisms to reduce stigma in all aspects, and not just for kind of political means. And if you've taken that training, you may remember that slide. So essentially took the media messaging training and said, let's use that positive language in our recovery stories and when talking about people who use drugs and the substance use disorders, to anybody we might be talking to, whether that's family, friends, neighbors, coworkers, media, public officials. And the overall crux of this was that it was solution focused and really talking about recovery rather than active addiction stories, which is, the most common recovery support that's freely available is 12-step programs, and has a phenomenon called war stories, which is used kind of strategically and otherwise, but oftentimes has horrendous language throughout that. So it was programming and helping people to get over that and tell a different type of story that used non-stigmatizing language. So tens of thousands of people were trained in that, and we saw some positive policy implications. If you're wondering, like, does this language actually matter? Here's our first instance of it more recently. So we actually saw some legislation passed in Maine in 2018 that actually struck all of the instances of substance abuse, addict, or alcoholic from a future legislation, but also previously legislation that was still on the books, and all of the divisions, departments, and programs at the state level that were part of the state government required them to change their name to use person-first language too. So it was no longer the Division of Substance Abuse, but the Division of Substance Use Disorders or something similar. But the reality is, right, and this is why this still matters. This is why changing the narrative needs to be a thing in 2019, even after the AP style guidelines, even after about 17 different studies on this. And it's because stigma and discrimination still exist, right? And stigma, if you're not familiar, is best defined by Lincoln Fellon as both a label and a stereotype. So in our field, when we're talking about changing the narrative, we have labels like addict that link a person to a set of undesirable characteristics. More often than not, especially amongst the general public, that's characteristics like criminality, things like dirty, or they're untrustworthy or amoralistic. And all of those two things work and coincide and kind of synergize into a stereotype, which means that beliefs about a group of people with a substance use disorder, in this case, can be applied in a general sense. So it's not about the person or their individual characteristics, is that as soon as I give a label to somebody that fits that bill, they must be all of those stereotypes. And this is how we see stigma to start permeating through the field. And unfortunately, stigma in and of itself, while I would say is a negative and bad thing, or it can be, it ultimately leads to a much kind of more abhorrent instance, which is discrimination. So this is the actual or explicit manifestation of some type of action that an individual takes when they believe stereotypes and then associate the label with others. So in our field, we see this often, right? So denial of housing and employment, or employment offers rescinded. We have these anecdotal stories that we've collected from a research project with nurses and other professionals actually having job offers rescinded when they disclose their recovery status in their pre-employment medical screening. We see forms of bullying and harassment. One needs to only go to the comment section of any story that gets posted on any news publication, especially around naloxone, and just seeing all the comments around "let the junkies die," etc. Bullying people and harassing those that may speak out in favor of it. And then we also see a condition, rule, or policy that disproportionately impacts only certain individuals, in this case, people with substance use disorders. And before I go back, a good example of that is actually the first iteration of the Parity Act. So the law of the land today is MAPIA, which includes parity for both mental health and substance use. But the first parity legislation actually explicitly excluded chemical dependency benefits. So we excluded parity for an entire group of people that had substance use disorders in a policy. That is in and of itself discrimination, and it's again a consequence of the most stigmatized disease and condition across the world, or one of the most, which is substance use disorders. Everybody loves Reagan. I'm sure we have some folks that actually remember him. I was not alive when he was president, but we see these are some examples of stigma using language and how this all ties together in our country. And this was something Reagan had said from the Oval Office. But let us not forget who we are. Drug abuse is a repudiation of everything America is. And this was an example that is tying drug abuse to being un-American to everybody that may misuse substances at this point when Reagan was said this. And this is going out to the entire community. So we see how these stereotypes, these labels begin to form in the public's mind, right? You'll likely remember this picture and the corresponding language that went with it, posted by some sheriffs in Ohio. We've actually blocked the kid's face, but this was something parents had experienced an overdose. They were called addicts in the post, and the sheriffs had posted this as a deterrent, which we know is not effective. But the reality and why this is discrimination outside of privacy violations is we would not do this if somebody was experiencing a diabetic shock or diabetic coma because they forgot to take insulin. We would not take the same actions or use the same type of language. So we begin to see disproportionately applied actions to populations. We'll go through some of these couple, and for those, if you have read the news anytime in the last 50 years, you've seen words like this every day across the world. Some of these are from overseas and our European neighbors. But we see language, again, like addict, that is associating people that fit that label with criminal behavior. And these are quite often used everywhere. Here's a screenshot of the words from the original Parity Act, where it did not apply to substance abuse or chemical dependency benefits. Luckily, that is not the law of the land anymore, but we have historic accounts of this left and right, again, littered with negative language, but also explicit actions. I'd be remiss if we didn't get to dispel some myths that you can also read more about on Changing the Narrative. But here's one of them, and this is from a group of Utah, came from a Fox affiliate, I believe. But a room full of junkies sitting around shooting heroin. Every time someone dies, another junkie whips out the Narcan. So not only are we seeing, again, explicit stereotypes associated with labels to a broad swath of people, but Narcan parties also are not a thing. It's not an empirically vetted occurrence there's not one documentation of this ever occurring, but we see these, so we have this coalition of negative language, stereotypes, labels, but also perpetuating myths about a population with something that we have no empirical proof that ever occurs. We'll skip over that one, but we see some more negative language with criminal behavior, and here we see the introduction of imagery too, right? The person or the person that they labeled an addict in this that's being let off in handcuffs, right? And the mugshot on the screen as well, coming, and the opioid wars at the top, harkening back to the war on drugs. So again, we could see the public's ingesting this information. So not only how negative language, stigma, stereotypes, labels are leading to developing opinions that can be applied to anybody that might be labeled with this type of words. We can see how all these things are connected, and media plays a big part in that, and what the general public and other people begin to associate with certain words and certain populations that may be labeled with those words. So we see all types of this, right? And a lot of this comes from, we'll talk about some, but these are from the original messaging trainings. One of the activities that was done there was to allow people in recovery and with lived experience, those who use drugs, to just call out labels that they had been called that they made them feel negative or that they thought were stigmatizing. And some of the more commons were words that we hear less today, but still quite often, depending on the setting. Addict, alcoholic, junkie, dope fiend, substance abuse, clean and dirty, relapse, even addiction in and of itself, when we ask people in recovery, is often viewed as a stigmatizing term because it's been so normalized. You know, when people on Facebook can post that they are so addicted to Starbucks, you know, caffeine use disorder is certainly a thing, but the normalization of that term has taken the weight off it on, and people will continuously say that it can be a stigmatizing word because they're not taken seriously, or the disease itself doesn't seem like a legitimate condition. So this is coming straight from people with lived experience. And these are some of the stereotypes that come with these labels, you know, and how did they get enforced? You know, the criminogenic behavior, the unworthy, the immoral that we talked about. If we look in our country, not only are we based on these kind of puritanical ideas and philosophies as from the founding of our country, which has led to just years of campaigns of indoctrinating the general public and everybody that makes up the general public, so all sorts of professionals, with just years of anti-substance use campaigns that started with the temperance movement in the 1800s and continues to the original war on drugs in the 1980s, which is probably no surprise to any of you, has never ended and continues to this day. So we've been inundating the public for 200 plus years on stereotypes tied to words that we don't use anymore, like inebriates, to the words that you see on the left that are still commonly used today. And these are some of the thoughts when we did some focus groups, when we started this work. These are some of the statements that are being used, and you can see how the public really feels about these words. These are not positive feelings, even though they are used, they're labels supposedly to describe a medical condition or a disorder, if you lean towards another kind of ideology of what substance use disorders are. And I ask each of you to think about, if we were doing this in person, we could do some roundtables, but think about as you go through this research, that's what we're about to get into, but think about stereotypes you've placed on others or have been placed on you and how those make you feel, because that emotional connection will help. If the empirical doesn't get you, hopefully the emotional connection will. That stereotyping people based on labels and based on generalizations is not a fun activity or a fun experience for anyone. So let's get right into the main research. So now is the fun part for those my other research minded folks that are on here. So our research team built on the work from John Kelly and Westerhoff and some others that had started with vignettes to really look at two words specifically: substance abuse versus substance use disorder. And vignettes are essentially a small paragraph with certain words changed, and then you ask how people would respond to them. We wanted to go more quantitative. We wanted to get deep down into, can we get a quantitative measure of the level of bias that may be associated with these words that the recovery community and people with lived experience had told us were negative. So we used a variant that's often used in racism research called the go-no-go association task. It's essentially a measure of response time. It's also been used in obesity, homophobia, and fear research, which you can definitely go out and look to see the basis of using a solution like this. But it allowed us to deploy it to a large national sample in near real time in a cost-effective manner, something that hadn't been able to be done in linguistics and stigma research within our field. And there is a video, which we will not be able to see, mainly because we're on a webinar. But this is the framework for these tests. So you can see within our original studies, we replicated John Kelly's research around substance abuser, testing that against a person with a substance use disorder. And then we also replicated the vignette study just to see if we could replicate the same findings. So we had vignettes using the hypothesized stigmatizing word versus the more positive word, and then did a distance or social distance scale measure to see if explicit, which if we remember from discrimination, is a explicit action that somebody takes or would take, versus implicit, which is a subconscious association. So that's the video we can't watch. That's what would be on your screen. So the 1,400 people that participated in our main studies, this is what they saw and went through a range of words to associate them with good and bad. So these are the results, and I will assume that nobody wants to spend time reading these. So essentially, we're going to tell you exactly what they said. And again, I'm happy to send the papers for those that are interested in the methods and the rigor that went into this. So what does the research say, and what do we know right now about stigmatizing words versus non-stigmatizing words, or more aptly known, positively biased words or negatively biased words? So substance abuse was the originally tested word through Kelly and Westerhoff. We replicated that and found and replicated those findings. So abuse versus person with a substance use disorder does invoke significantly different and greater negative explicit bias in both treatment professionals, which was the Kelly and Westerhoff study, but also in stronger or greater negative implicit bias in the general population from our studies in 2018. Opioid addict invoked greater negative explicit bias and implicit bias in the general population. And this came from Kimberly Goodyear, from Brown, I believe. That came out in early 2018, and we replicated again from our team in 2018 as well. Alcoholic versus alcohol use disorder invoked greater negative implicit bias in the general public. Relapse, which is not one that we hear most often, except when you talk to people in recovery, because it invokes feelings of negativity or failure. While in and of itself, these are somewhat divergent from the other words, it's not that it is negative. It's that recurrence of use as the hypothesized positively biased term did invoke greater positive implicit bias in the general public when compared to relapse. So again, not that relapse was inherently more negative. It is that recurrence of use as a replacement term does invoke greater positive implicit bias. Medication-assisted treatment, which is one that we talk about often and is, especially with all the federal funding in the midst of an opioid, spikes in opioid overdose deaths over the last decades. We wanted to test this word. But pharmacotherapy, which is used in physical health care for a lot of medications used as treatment, also invoked greater positive implicit bias in the general public. So match in and of itself wasn't significantly more negative. It's just that pharmacotherapy was more positively biased. And when we couple that with the recovery community's anecdotal or qualitative research saying that they are stigmatized when they are using medication-assisted treatment within group settings and other recovery community settings, it gives us a little bit of a stronger sense to do that. And I will add here, just because we're on a Changing the Narrative webinar, that medication is not assisting the treatment. Medication is the treatment. So even the term before MAT does not make sound logical sense, just because that's not what is occurring within those treatment settings. Medication is treatment. Medication-assisted recovery is a common term used in the recovery community. So we tested that with long-term recovery, and these terms both induced or elicited strong and significantly stronger than negative positive implicit bias in the general public. And then finally, addict versus person with a substance use disorder also invoked greater negative implicit bias in the general public. So what does that all mean? And I think it's important as we look at those are as of right now, those are the terms and the positive replacement terms that have been empirically studied across the range of research. There's certainly more. We've seen movements to want to test cannabis versus marijuana, especially with the racist kind of undertones and history around marijuana versus what would more accurately be called cannabis, as well as continue to do some research to look at things like treated and untreated. Actually, more recently, Johns Hopkins published a study comparing safe injection sites to using overdose prevention sites, with OPS doing much better. So there's still a lot of work to do, but I think of the ones we've tested, so these three on the screen and the other four are the ones most often used in the field today. And this is strong enough at this point, after 2 decades of replication research on some, but also just the most rigorous testing to date, that gives us a reason not to want to use these words. Because again, why does this matter? Not only are we talking about millions of people, but we are talking about a significantly and systemically oppressed population that is underfunded, often discriminated against, doesn't seek treatment, not only due to stigma for the most often cited reasons. It's not access to healthcare or having insurance coverage. It is stigma-related reasons that people aren't seeking care in the first place. We begin to see all of these reasons why if language can be changed to invoke either positive bias or mitigate negative bias that may be associated with improvements in health-seeking behavior, funding appropriations and support from the general public and policymakers. We begin to put together this picture of not only why language matters, but what the research tells us about what we should change some commonly used phrases with to make a more positive impact. I'll breeze through some of these, and I don't know how I'm doing on time, Zach. I think I'm still pretty good. So we also did a range of other studies, right? So looking at the future of linguistic research, we did a series of Delphi studies. That method was popularized by the RAND Corporation back in the early 1900s, talking to both people in recovery, family members, both family members of people in recovery and those that have experienced a loss due to an overdose, and then also treatment professionals, asking them essentially in a methodologically rigorous way, what we used to do in those trainings from the recovery messaging, what words are most negative and what words are most positive. We're not going to go through all 60 of these, but on the negative side, from people in recovery, crackhead, junkie, abuser, addicts, felon, criminals, all words that we hear often characterizing this population. I mean, these are people telling us kind of at large that these words are demoralizing and negative to them, and they're some of the most demoralizing and negative, and it's abhorrent that they're the most often used when we look at the popular media and general conversation. For family members, we see a lot of overlap, so junkie, dope fiend, drug abusers, dirty and clean, especially when applied to urinalysis. And in professionals, see again, similar overlap, junkie, dope fiend, addict, criminal. And then the biggest takeaway on the positive side, which I think we all should internalize if you take nothing else away from this, anything that is person first or attempts to restore or invoke humanity of an individual is often listed in the top 5 of the most positive words across all groups. Going so far as even for professionals, the number 1 positive word or phrase is person and human being. I mean, that's really what we're talking about when we talk about positive language, is that if we can not use labels and just if we're trying to remain or retain or re-invoke humanity of the individuals that may have a physical health or behavioral health disorder, that's what we should seek to be doing, rather than labeling, which can result in negative stereotypes and all of the negative impacts we've already discussed. Some of the other research we've done, we actually looked at health professionals specifically with both addict and substance abuser compared to substance use disorder. And the reason this was done is there was a theory that health professionals of all sorts actually had higher levels of bias amongst and compared to people that were not in the health professions. And that's essentially exactly what we found, especially for substance abuse. So health professionals compared to the non-health professionals had higher levels of bias across the board, but the negative association with the term substance abuse was the only significant difference. So we're looking at a term that is used in medical records and often in all medical settings to describe the population who uses substances and those with substance use disorders. And every time that word is used, at least at a population level, we're invoking the most negative bias that we can amongst those professionals. So again, some greater evidence that maybe we should be changing the way that we speak. For people in recovery, so we've done a range of research around, because people in recovery often use some negative terms. We actually found, whoever's typing, if you could mute yourself, that would be great. Thanks. So we actually wanted to test, do people in recovery have a strength or a negative bias towards words that they often use as a form of catharsis or a form of identity in their own recovery pathways? Or would they have a more positive bias towards these words that were stigmatizing in the general public? We actually found the first, which was a surprise to us, given all the feedback we had gotten from people in recovery, especially those in 12-step pathways. By and large, again, at a population level, so this is not individual level data, the negative association with addict and bad was significantly different and greater for people in recovery versus those that weren't, with no differences across the other three. So again, an important takeaway that words most often used by people in recovery, and especially in some pathways over others, is actually invoking or eliciting significantly greater negative bias. So again, so some food for thought, right? And on that last point, I think we'll hit on this briefly just because it's important, and it harkens some to the AP guidelines. For people in recovery, so individuals labeling themselves, they should always retain autonomy to label themselves whatever they want. So if they want to call themselves addicts, alcoholics, as a person in recovery, if I want to do that, I should have that right. But nobody else should be able to label that or use that label to me without permission. So we see this in the AP guidelines, like I mentioned, that we also see it, the Philadelphia Inquirer guidelines here where I'm at, is that addict should only be used when it's in direct quotation, when somebody used it about themselves. And I think that's an important takeaway, because we can't take around. We've gotten a lot of feedback, especially from people who use drugs in the recovery community, to try to promote an idea that people can't self-label however they want is just a step too far. But that doesn't mean using this type of language publicly or in non-recovery settings is helpful. And that's the caveat to this, to give people information to know that you have the right to self-label, but know as you choose to do that, there may be negative impacts from it. We're going to skip over this. If you're interested in some more of the recovery-related language usage that applies to our research, we can definitely talk more about it. We've kind of labeled this phenomenon dynamic labeling discernment, which essentially means people in recovery can and do use positive language in public settings, and then they will use more stigmatizing or negative language in private recovery settings as needed. But they can dynamically switch and discern based on the setting that they're in with high proficiency. So kind of in closing, right, is what we've found that, stigma is a direct barrier to accessing care or treatment. We talked about that. It is about 39.7% looking at the last national survey on drug use and health were cited as the top reason for people that perceived a need for treatment actually not accessing it. 40% is quite a large number. It also results in a lack of general public support for legislation that provides a range of helpful activities to support recovery and provide harm reduction services, et cetera. And there's been some studies that shows that it also impacts the quality of healthcare delivery given by medical professionals. All really important. And right now, and I think it's worth noting, because fentanyl is out there, because the risk of overdose is quite high amongst varying populations. So if all of those things, again, if they act in concert or even in isolation, they can very seriously result in death in this day and age, whether it's from opioids or alcohol or any other substances. Here's a screenshot. If you like these tools, we actually we translate all of our research to be used by professionals, whether they're journalists, media professionals, healthcare professionals, academic institutions. We created some infographics that are some quick guides of when to use this language. And you'll see that of all of the negative words, unless you're in a mutual aid meeting, shouldn't be using it. There's no reason to use this. And if you're a media professional or a medical professional, or if you're working with clients as a therapist, there's no reason to be using the terms addict, alcoholic, substance abuser, opioid addict, relapse, or medication-assisted treatment anymore. But just saying don't use something isn't good enough. So you'll see all those shiny green check marks at the bottom that are good to use in any setting, no matter what type of professional you are. And I think it's important, though we are just now getting into launching some of these pilot studies, is that language is really the tip of the iceberg. When we talk about changing the narrative and the research, imagery is critical, and it can have a similar impact from the pilot data that we have. So all these images to the right, you'll often notice accompany every single story that has to do with the opioid crisis or epidemic, kind of self-titled in this day and age. We're talking about addiction or harm reduction or overdose prevention sites, anything that has to do with the field. These are the types of images that are often shared with those stories or chosen by editors. And what we found is that all of these can have a negative, with negative content, can reinforce negative stereotypes that are held about individuals both in recovery and those with a substance use disorder and those who use drugs that may or may not impact their help-seeking behavior, the public support, all of those things we talked about with language. It's likely that images are having a similar impact. And one of the ways that we're going to look at actually addressing that for those that want empirical proof before you make any changes, especially those that may be journalists, we're actually, the theory around this is that images can prime negative responses or positive responses. So we're looking at a NIH R21 to actually test this priming theory using both audio and visual or images to see if we can prime and manipulate the magnitude or strength of negative and positive associations, with the goal of being able to tell journalists and other media professionals that the images you're using, the words you're using when you're recorded, if you're doing audio, all have a detrimental impact, just like the written word. So we don't know that for sure yet empirically, but that's the direction the field is going, to really begin to partner with and help educate journalists and other media professionals. So in closing, and we can go to some questions, right, it really does start with us. So changing the language of how we talk about substance use and recovery and those it impacts has to start with those that are on this webinar, that have read papers, that are out there doing this work. Because if we don't start, if we don't educate others and call in instead of out, because calling out doesn't always work, we have to choose to do these things ourselves in all of our kind of activities, or nobody else is going to learn and do differently. And these are, again, a quick snapshot of how and what not to say and what to replace it with. For media guidelines, if you are a journalist and want some resources, we have put out some positive language guidelines that we use at all of our events, and we give to all of journalists that ask us for interviews, saying this is how we will speak. And if you can't follow these guidelines and can't not write these words in stories and headlines, we will not be an expert in your story. But it just goes through a range of things like the ones that we've already talked about, but it also talks about criminal, felon, and convict, not using those, not saying homeless, not using addicted babies, which is another myth that you will hear about and read about on Changing the Narrative, and then all of the positive replacement terms that can be using that. So if you're interested in those, would be helpful. They'll definitely be a resource you can have. And health professionals in a similar manner. If you're so inclined, we actually have a person first pledge, which is not actionable outside of the case, that it allows you to educate yourself on everything we've talked about today and make a pledge that you will do something different. So whether that's organizationally, if you're a leader at one of those, or if you're a journalist and you want to take it to your editorial room, again, it all starts with us and taking some change. And whether that's being part of Changing the Narrative or taking a person first pledge, we can all make a difference, because at the end of the day, we do have to change the narrative. People are suffering. And while it takes resources to make systemic change, right? We need millions and millions of dollars to reform healthcare systems and substance use disorder support services in the US. Changing our language costs absolutely nothing. So if you want a low resource, low cost intervention that you can make a change today and impact people's lives, changing the way we talk is the easiest way to do it and doesn't cost your budget line items a penny. So I will end there, and I appreciate, again, Zach, Leo, and the rest of the Changing the Narrative folks for allowing me to present to y'all today. I'm happy to field some questions if there is some, and we'll go from there.
Thank you, Robert. Clap for Robert. That was incredible. Yeah, I think, hold on, there's sirens in my background. They're probably arresting someone for no reason. Okay, so yeah, like you're saying, Robert, there's research. This all makes infinite sense, and yet changing the narrative, influencing media coverage, changing the way people talk about this issue is no small task. And I think what we can do is open up the floor to talk about people's takeaways, people's thoughts, people's ideas. eclectic. I think it's a she, right? She in the chat said that the stigmatizing images really come to mind and they make it harder for society to, quote, see addiction in a different way. And yeah, if we want to talk about images, language, anything, any questions, the floor is open, people.
Yeah, Zach, Bill Williams here. Can you hear
Hey,
me?
Bill. Yep. Hey.
As I thank you for this. As I was listening, one thing came to mind. Um, it'd be wonderful if we could get insurance companies, as they describe their policies and as they attempt to comply with parity, um, to have them use the same positive language in in their descriptions of what their policies entail and what they do. I bet if we if you took a look at what insurance policies say right now, I'm sure it would be horrifying.
Yeah, I think you're right, and it's luckily, and I say this loosely, right? Any big entity is like a bureaucracy. It's like steering a big ship. It's very hard to turn, but once it starts to turn, can do so very quickly and brings a lot of things with it in terms of momentum. So we've seen some initial reaction to kind of these integrated systems that are both payer and healthcare providers, so managed care organizations like Atlantic Care, like Kaiser Permanente, that have latched onto it, and we've gotten I think, some immediate interest from places like Independence Blue Cross, United. I think the biggest thing for them is enough people have to say it and request it, and I think as this movement grows, I think one of the things that is absolutely great activism, because you're absolutely right that changing it there can it influences a lot of people and it influences a lot of policy. So I think there's some starting momentum, but I think more people have to begin to request it that have relationships with the biggest payers, and CMS is included in that, right? Like, this isn't just private corporations that happen to be payers, but this is Centers for Medicaid and Medicare. Their policies are just as bad. So I think we have a lot of work to do, but I think it'll make positive momentum as more could begin to adopt it. I think it's a great idea.
There was a question from Lizzie. Lizzie, do you want to unmute yourself and ask away? Go for it. Let's see here.
I know there was a question from, I'm going to say Carolyn, but I don't know if that is correct or not. Just looking at the chat. So to answer your question, so secondary analysis looking at demography. So no, because it was not the secondary analysis is not. I think I muted while I was trying to answer that.
Sorry.
Can you hear me now?
Yeah.
All right. So Carolyn had asked a question around if whether this kind of linguistics research had been explored around demography, so class, race, gender, and there's some others that would be important there. And the short answer is some of it. We have not done a secondary analysis on our data set yet, looking at those things specifically. The only study that I'm aware of right now is the Kimberly Goodyear study that specifically looked at gender. So that whether or not, again, this wasn't gender identity across the spectrum, but specifically male to female, to see if stigma was moderated by the gender expressed within the vignettes. And they found that stigma was greater when the person in question in the vignette was a female. So stigma was higher or greater in those cases compared to vignettes that using male. So I think it's, again, we think of, there's two things to characterize here, and I think it's an important question to ask. When I was at Johns Hopkins giving a similar presentation, we had a similar conversation with one of the researchers and professors there. Language does change. It depends on context. It changes based on demography. We've seen reclamation of negative words happen in communities like the LGBTQ plus communities and communities of color. That may happen here. We've seen words mean different things to different people. So we do have to begin asking those questions, especially around cultural and demography lines. But this research is certainly in its infancy as applied to substance use. So I think it's a direction that we need to go. The other problem is that there is not a tremendous amount of funding to do stigma and language research, especially in substance use. And it takes a lot of money. We got lucky to do the study we did with some seed funding from Penn. But there's not a whole lot of federal funding or grant applications on this topic that have been reviewed favorably, which impacts the quality of research and time and commitment that can come out. So I think all of us that do research are, well, I won't say everybody's a social justice minded person. I'm a social worker, so I am, and see the need. I think we all want to. It's in our plans to do a secondary analysis looking at demographic characteristics as moderators within the analysis, because I think you're right, and there's something there. And I will say that, so we did not include people who use drugs or were actively using in our sample sizes, primarily because of IRB. It was a hill that we could not overcome with them. We have a lot of education to do with IRBs to be able to engage in approved research with people who use drugs, at least at my institutions. So that is why they were not included. But yes, they absolutely should be, and you're right.
So we've got a couple of questions. Ben, are you unmuted?
Yeah, I'm here. Is now the time? Can you hear me okay?
Yep.
Okay, cool. So I guess my question is, and this is, certainly something that comes up at Leafly, but I was also, the first half of this week, I was in New York for an editing conference, and people were talking about how to write headlines and decks and, web slugs and things like that. And so I think I'm speaking for broader than just my publication, but publishers will often try to decide, what terms to use based on what will actually attract the most traffic through Google search and things like that. And that seems to me to risk perpetuating this kind of vicious cycle where, people keep using language because people have historically used that language, and then that perpetuates the use of said language, right? As someone who's just one person at just one publication, I'm curious, how, whether it's changing the narrative or this community more broadly, like, does anybody have any ideas for how to counteract that? Because, I can put out a style guide, but it may not mean anything to even my higher-ups, let alone, publishers at, AP or USA Today or people who have a lot more sort of mainstream exposure. And I don't have a solution to that myself. I'm just wondering if anybody has ideas.
So one of the things I can tell you, and I don't know if it would apply to marijuana versus cannabis, but I think this is often, especially in for-profit places like yay capitalism, right? This is a common question. We experience this with substance use disorder treatment centers. If we change all of our branding and all of our copy on our websites, including keywords and our slug titles, like you said, but even the narrative copy on the website itself, our SEO will take a hit. And two things happened. One, we did some test runs with treatment centers that were willing to take a shot. They lost almost nothing from SEO. And the reason for that is because at that time, there was so much pay-per-click advertising that SEO didn't particularly matter because everybody that was getting clicked was bidding, $90 to $120 per click, and people were hitting on the first three on a Google search. But even on their organic rankings, from when we looked at after the copy and keywords were changed, it didn't suffer that much. And I would imagine, at least right now, with all the changes going on at Google and Legit Script, and organic searching, keywords that are actually using negative words, because we work with Facebook, Twitter, and Google, and are supplying the lexicas or dictionaries of terms that we're finding to be stigmatizing or problematic to them, and they're actually being reducedly ranked. So again, I don't think that necessarily applies to marijuana versus cannabis, but certainly for addict, alcoholic, and substance abuse, organically from an algorithmic standpoint, those are not going to continue to do well. And I don't think, again, I don't think the hit to SEO, at least I just don't see that being a big shot, especially if they're going to be artificially limited based on from search engines that know or getting fed information that these words are bad. So that's the first kind of pragmatic answer. The realistic answer that I want to scream from the rooftops at these people is, I get it that you have a bottom line, you have a profit, but it's the right thing to do. And at some point, like, I realize that's not enough of a motivation, but it has to be entered the conversation. Like, our SEO be damned, we're hurting people. And I think that has to at least enter into the pragmatic conversation of, it may not impact our bottom line as much, but like, they have to be called out to some level, because it's not okay to continue.
Yeah, thanks. And just hearing you say it is really helpful because, as someone who sometimes has to make those cases, it's nice to know how people in the rest of the community are talking about it and things to do that. So yeah, I thought of this when Cosmopolitan editor was talking about their CBD coverage, and I was like, oh dear Lord, this is dangerous. So thanks.
Yeah, hi, this is Carol from Families for Sensible Drug Policy. How is everybody? And thank you so much for this conversation.
Hey, Carol.
Hey, so I think these are great questions, and I'm thinking as the topic is being discussed that we could make a campaign that could kind of have a good list, and as the voice of the families, we could kind of put the same pressure on them by incentivizing them to find value in being on our list and supporting our families. And we can talk more about how to expand that, but I know it's worked for universities and different entities when there's actually been a calling to come to the greater good, and they feel compelled because their marketing is going to depend on the families enrolling their subscriptions with their papers, and that can present a big bottom line issue for them if it's not favorable.
Carol, I think that's a great point. And as you know, families, parents, especially families who've been impacted in any way, I mean, can be a huge force for change in this arena. And if there's anything that, any initiative that gets families involved in using the language that we've been talking about, I think that can make a huge impact. So definitely a good idea to, take that track down and see where it goes.
Yeah, kind of like take the pledge. We can make it a thing. So I'm excited to listen to everybody, and I, again, thank you so much for this, and we can talk more offline about that.
You're welcome. Thanks for being here. So
Yep.
Lizzie Unger had a question for, I think, you, Robert. Do you have any suggestions for introducing terms that people may be unfamiliar with, like pharmacotherapy? So maybe this is getting at, like, in journalism, we try to refrain from clinical jargon and overly medicalized terms. And, with pharmacotherapy, it's obviously sort of a mouthful. It can be hard to pronounce. So I think this
It's
gets
fun to
into,
announce though.
yeah.
Is so two things on here. So one is we had manipulation checks built into our research, specifically with the general public. So that 1,400 person sample, none of which, again, varying demographics. So education, SES status, including education, backgrounds, ages, genders, etc. Even though we hadn't done a secondary analysis, but like 98% were able to conceptualize what pharmacotherapy meant. So I think there is a misconception that the general public does not understand words. That it certainly doesn't mean that health literacy, especially behavioral health literacy, is as high as we would want it. I think it's a great question, but I do think we need to at least maybe challenge the notion that the general public is not as kind of aware, or the ability to define terms or know what they mean, kind of writ large, again, at a population level. And I think that's important because we had the same question. Are people going to know what this word meant? And at least in the study, and again, it's only 1,400 people, but it was randomized, did know what that word meant. But I think we saw this before too. Like, so editors that don't want to say substance use disorder because nobody knows what that is, we generally find that not to be the case. The general public is pretty aware. But so that soapbox answer aside, I think a really great way to do it is to, depending on what setting you're in, what kind of profession, is to crosswalk terms over time. So create a messaging plan that makes sense for your organization or your entity, that we're going to crosswalk over the next 12 months to get people here that hear our messages. So it may be that you issue your next range of marketing materials or blog posts, etc. Use MAT and pharmacotherapy interchangeably. Maybe you issue a press release saying that specifically calls, we are about to change all of our language. Here is a guide to what this language change means. I think there's some health communication strategies that make that translation easier. And the third thing I would say is that as a general field and as a country, perhaps even globally, we've done a lot of investment in health literacy on the physical health side. There needs to be investment in time to behavioral health literacy. We should not use words that are not stigmatizing because the public doesn't understand them. We should educate and invest resources to help the behavioral health literacy of the public grow, would be how I would address that.
So it's 4 o'clock And if people have places to go and things to do, we understand if you're dropping out. Robert, I don't want to keep you any longer than necessary. There's one last question. Maybe we can end on this, or if people are engaged and want to keep the discussion going, I'm happy to leave the chat open for a little bit longer. But the last thing was about on-air broadcast, like NPR, for example. Deirdre asked about basically broadcasters in real time, perhaps on air, maybe violating their own organization's person first policy. And I can just attest in my own experience of being interviewed on air or live or even in podcasts or anything, it is really hard to interrupt an interviewer and correct them in real time. And I've sheepishly not done it in certain instances, and sometimes I have stepped up and have interrupted and have done it. And I think when it comes to broadcast language, I've analyzed and looked at it much, much less than print, just because print is easier to search and easier to find. So in the future, I think thinking about broadcast language should definitely be on our radar.
Yeah, and I couldn't agree more with you. And I think we do need to figure out a way to analyze it, and whether it's some of the big ventures that if they have to closed caption their stuff, right? So if we can get some type of way to get those logs to be able to do some type of analysis on it, it'd be interesting to see kind of what the takeaways are from on-air personalities and the language they use. And there's two things I think that I would add, Deirdre, to your question is the calling out entities. So calling out NPR, calling out news stations, calling out publications, kind of at an organizational level, it does a lot of good and it has some positive impact. So calling out NPR when they issue a story about fentanyl overdoses through the skin, which is another myth. Calling them out on social media and writing them and emailing them, et cetera, is a positive tactic, and it's actually resulted in some retractions and changes, et cetera. But calling out individuals is much less effective. So typically, my strategy is to call out when it's an organization or an entity, and to call in and to educate when it is an individual, whether that's an on-air personality or other. So having whether it's through email or phone or in person, having a one-on-one conversation that's focused on, rather than assuming the worst, being like, hey, I don't know if you knew this, but those words actually can lead to explicit stigma amongst a variety of stakeholders. Did you know there's some positive replacement terms that don't take that much longer to say, and here they are. So it's call out organization, call in individuals is my strategy. But social media is a great tool. I think every day Ryan Marino and so many others, including Zach and people on this call and changing the narrative, call out organizations and outlets every day. We don't win every time, like we don't get them to retract or change, but oftentimes they do. And I think the more that we can have a resounding community that is not allowing people to talk this way, or educating if they're individuals to change the way they talk, the better, right? Like there's certain words amongst populations and communities we would never say. And part of the reason that we've gotten there is because the anger, the vitriol, the amount of education that's gone into making sure, words like mental retardation or the N-word, if you're talking about Black communities or Black individuals, crazy is another one. Like all these different types of words that we don't say is typically because the amount of anger, like people wouldn't dare say those. We have to get to that place between a combination of call out and call in, depending on the entity, to get it to where this language isn't used anymore.
Thank you. I appreciate that. And I have sent in, I often listen to NPR in the evening after the shows are over, and it's just mind-blowing to hear someone like Terry Gross say, and the addicts were, in her nice, calm voice, it's like, no. And so I send them sometimes copies of their own, this is your policy, that you won't use words like this, and this is why person-first language is so important. But I never hear back from people. I think that someone like you in this organization or us together have much more power than just me sending in as a professor at Temple going, hey, people first language is better. So thank you.
Shout out Temple. I'm also in Philly, so glad you're here.
I saw that.
Yeah, I think that's one of the great things about changing the narrative as an organized collective, especially with some of the really kind of renowned experts that are a part of it, and the more that each of you gets involved, I do think there's more power in an organizational ability because it is a collective, and there's it represents a lot more kind of collective impact. I don't think that should dissuade us from doing it individually and continuing to do that like you do. But I do think the changing the narrative, Northeastern, each of us at different institutions, the chances of making change may be higher when it comes through that mechanism. And I think that's one of the great things about changing the narrative even existing. And on that note, Zach, I do have to run. Again, thank you all
Yes.
for letting me be here. I hope to and look forward to future conversations on Thursdays, and I hope everybody enjoyed what you heard today from me.
Yeah, Robert, that was a great presentation. Thank you so much for your time and for kicking off the Changing the Narrative webcast. We do want to make this a regular thing. And on that last point about this being a collective, and it does start with us, and we are in unison together on Twitter and social media, calling out the organizations and news outlets that are some of like the worst offenders, and we will see how it works. And of course, we're going to be testing out different strategies as to how to best engage and figure out what works and what doesn't. And I was just thinking, like, when it is a news organization, figuring out how to get their attention. Like Deirdre, I've also emailed news outlets and get nothing back. So is it naming and shaming on social media that gets their attention, or is it quietly sending emails and being nice and polite? Yeah, we'll be figuring out what works as we move forward. So on that note, if there's any last questions, any last points, we can close this discussion. Thanks everyone so much for taking time out of your days to join us. I think this was a really excellent presentation, and we want to do more. Okay, judging by the silence, I'm guessing everyone is heading out. So thanks again, everybody. Thanks so much.